here in person and online. Len is away today, so I am going to introduce our speaker, Dr. Niraj Patel. Patel is as pediatric allergy and immunology specialist. He's in North Carolina. He's an associate professor of pediatrics at the Division of Allergy Immunology at Duke University Medical Center. He received a medical degree from the University of Louisville School of Medicine in Kentucky. And following the completion of his residency in pediatrics there at the University of Louisville, he went on to complete fellowship training in both pediatric infectious disease and allergy and immunology at Texas Children's Hospital, Baylor College of Medicine in Houston. During this time, Dr. Patel also received a master's degree in clinical investigation. He's a member of CIS, AI, ACAI, and Infectious Disease Society of America. He has authored or co-authored numerous articles published in peer-reviewed journals, including the New England Journal of Medicine, Journal of Allergy and Clinical Immunology, and Journal of Clinical Immunology. And he currently serves as chair of the ACAI COVID-19 Vaccine Task Force Committee and was awarded the ACAI Distinguished Service Award in 2021. And Dr. Patel's academic and clinical interests include primary immunodeficiency disease and infections in immunocompromised hosts. And there's a little information about free time. Dr. Patel enjoys spending time with his wife, gardening and shepherding his 3 children around town. And he's also a national gold medal champion at Taekwondo. So welcome, and we look forward to your presentation.
Thank you, Dr. Lang, for that wonderful introduction. Good morning, everyone. Again, I'm Niraj Patel, and I practice primarily clinical immunology. The talk for today is going to be something a little bit different than primary immune deficiency disease, but something that I think we are seeing more of in the clinical space. And I was told to cater this talk to allergists, and so not primary immunologists. And so I titled this B-cell depletion and immunodeficiency, what the allergist needs to know. These are my disclosures. Now, before we get started, I just wanted to tell you part of what we do as allergists, immunologists is we try and protect the patient, right, with vaccines. And so not only do we take care of patients from an immune standpoint, but we also try and afford them protection. Now, a couple of years ago, we did have a flu vaccine shortage. So fortunately, we've gotten some advice on what to do in case there's another flu vaccine shortage. So first of all, citizens should remain at peak health at all times. I think that kind of goes without saying. I can take Galap, which is a Chinese herbal remedy, which has never been proven not to work for the flu, kind of one of these double negatives. And I think the most important is you rent a baby for $10. You can actually do this. You rent a baby for $10, take him or her to get the flu shot, and then right at the last minute, you put your arm in front of the baby so that you get the flu shot. So why do we need to know this stuff, right? B-cell depletion, immune deficiency. If you've gone to the American College, the most recent meeting, the Quad-AI, what is being talked about is patients who get biologics. They get biologics, they're historically previously healthy, and then they end up having issues after that. And it's usually issues with their immune system. So we know that biologics can cause secondary immune deficiencies, but the reality is that the use of immunosuppressive biologics is on the rise. There are more and more biologics that are being developed and approved by the FDA year after year. And there's an increasing reliance on the allergist for management. So these folks come into the allergy clinic, and we as allergists are going to have to know what to do. So what I'm hoping that you'll take away is at least, be able to recognize some of the common causes of secondary immunodeficiency, or SID, including specific germs. What I hope to impress upon you is recognizing the immune evaluation of patients receiving B-cell depleting agents, and then when to put these folks on immunoglobulin replacement. Right? That's not always clear cut. And then finally, again, knowing that vaccines are an important consideration in patients receiving B-cell therapies. We want to protect the patient, but sometimes we also need vaccine responses. And how do we deal with that in somebody who may be immunosuppressed and try to figure out whether they have an immune deficiency and require immunoglobulin? And I'll talk a little bit about that. I was actually talking to a gentleman before this talk about a patient, and so here you go. This was actually a real patient referred to me by an allergist in the community about a year ago. So it's a 62-year-old female with hypogammaglobulinemia. She was diagnosed with MS, or multiple sclerosis, in 2015. What she did is she got started on ocrelizumab, or Ocrevus, which is an anti-CD20 antibody. So basically, this antibody goes around and it blows away or destroys B cells. B cells are the cell that produces antibodies. She started that in 2018, and she currently continues that every 6 months to control her MS. Before she was referred, she had 2 pneumonias in about a year timeframe. She had a chronic cough, and she had a CT scan in 2023, and that was her last pneumonia. So, radiographic evidence of pneumonia. So that's not good. And then getting more history, when I saw her, she had 3 to 4 sinus infections a year. She had 2 ear infections in the last 4 weeks. So this is odd, right? When I see an adult with ear infections, adults don't get acute otitis media. That's a pediatric disorder, right? She actually had an acute otitis media that caused a perforated tympanic membrane, and she went and saw ENT. She's had chronic rhinitis. Her skin test was negative, and she has a family history of an autoimmune disorder, Crohn's disease, and she has polyps. So what happened, right? She underwent an immune evaluation, given that history of frequent illnesses, the anti-CD20 antibody, with concerns of hypogammaglobulinemia, and she was hypogammaglobulinemic. Her IgG was 383, and the normal range here is 586 to 1602. Her IgM was normal at 75, and her IgA was also normal at 93. The second component of the immune evaluation is qualitative. So how well do her antibodies work by assessment of vaccines? So her tetanus response was absent, her diphtheria response was absent, and her pneumococcal titers were also completely absent. She had no pneumococcal response. So, what happened next? To just like any self-respecting allergist immunologist, don't see something we like, we vaccinate somebody. So this person got the Pneumovax polysaccharide, the PPSV23, and then post-pneumococcal titers. So this was a challenge to see whether she would produce a response. And so 4 weeks later, she had post-pneumococcal titers, and it looked the exact same. She had no response, 0 zip. As part of an immune evaluation, we looked at her T cells, and her T cells were normal in number, CD3, and then CD4, CD8 T cells, T helper and cytotoxic T cells, normal. But you'll notice that her B cells, as evidenced by CD19, mature B cells are 0. And that is a result of the Ocrevus, right? She still continued to get that every 6 months. So here's a couple of questions, right? What do you do with this patient? Do you monitor only, right? Do you start antibiotic prophylaxis? Do you start immunoglobulin treatment? Or, would you rather do something else? Maybe refer on to somebody else, So we're going to come back to that case, and I'll tell you kind of, as we walked through that case, how we use information such as guidelines and clinical history to kind of come up with a decision on what to do. And I'll tell you, in the last probably 6 months, I've gotten about 6 referrals for secondary immunodeficiency related to a biologic that somebody received. So this is out there, and it's only increasing. So immunodeficiency, we're always taught that patients who have immune deficiency are more susceptible to infections. That makes sense. Their immune system is not working, and the keys are that the infections are more frequent. So they get more illnesses than the average person, but sometimes it can be unusually severe. So they can have a pneumonia that winds up as an angina with pus in the lung, or I have a patient, an adult who had sinusitis who ended up having a brain abscess. That's a rare complication from a common infection or prolonged. You hear history of kids and adults saying, I got this cold and then it turned to bronchitis and pneumonia and it didn't go away until weeks down the road. Here's the deal, and I think this is where we struggle with immunology, is that there's non-infectious complications. So there can be lymphoma and autoimmunity. And if you think about somebody who comes into the office with MS, right? That's an autoimmune disease. And then you end up doing this screening test and they look like they have no immune system. And the question is which came first? Did their autoimmunity come first? You blasted them with a B-cell agent and then they became hypogammaglobulinemic? Or did they have an underlying primary immune deficiency disease all along with an increased susceptibility to autoimmunity such as MS? And sadly and unfortunately, most institutions and most allergist immunologists do, and most subspecialists, neurologists and hematologist oncology, we're talking about things like that. Most folks don't actually obtain any type of semblance of an immune evaluation prior to the initiation of biologics. And I think that, we're going to talk a bit about that. And I think that that's probably not necessarily the way we need to do things. So there's two types of immune deficiency. There's primary immune deficiency disease, otherwise known as inborn errors of immunity. That's the one you're born with. But that is actually what we're not going to talk about. We're going to talk about the other type. We're going to talk about the secondary immune deficiency. These are the things that you acquire along the way that causes your immune system to become defunct. And actually, those are more common. So here's just a broad view of inborn errors of immunity. And you might wonder, you're like, okay, well, you had primary immune deficiency disease, and people are pretty familiar with that. And now you're talking about inborn errors of immunity. So, what gives? What happened? And people, the correct terminology now is IEI, or inborn errors of immunity. And, people don't just present with recurrent infections. They have complications as a result of their inborn errors of immunity. So things like autoimmune disease, lupus, rheumatoid arthritis, ITP, autoimmune hemolytic anemia, inflammatory bowel disease, or they have an increased risk for lymphoma. So, or oncologic disorders, gastric carcinoma. And so I'm not going to go over all of these things inside, but this is just to give you a flavor of what we're dealing with when we deal with somebody who has an immune deficiency. And again, this is the reason why this was sort of expanded, this kind of terminology, because we weren't really dealing with just infections anymore. Yeah, some people have just infections, but others have other issues. And I think the onus is on us as practitioners to really figure out, okay, is this just a secondary immune deficiency, or is this an inborn errors of immunity where the autoimmune condition, the malignancy, was really unmasked, right? Hopefully that makes sense. This slide just shows you what are some common causes of secondary immune deficiency disease. And I will tell you, the one that we're seeing more in clinical practice is really drugs. Drugs, and in particular, anti-CD20 antibodies. We're going to talk a bit more about anti-CD20 antibodies. But, we don't really deal a whole lot with transplantation and primary allergists, but we might deal with it on the back end, solid organ and bone marrow. And then something to be aware is protein loss, right? You can have hypogammaglobulinemia, low immunoglobulin, but then you have to figure out whether it's something that your body doesn't produce enough, which generally imparts some type of immune deficiency, or are you losing too much immunoglobulin faster than you can produce it, sort of a loss kind of thing. And the two most common ways that people lose it is through the kidneys, renal, urinary loss, and through the stool, protein loss. So you really have to have a lot of loss, a lot of stool loss in order to be hypogammaglobulinemic. So these would be folks who present with protein losing enteropathy, 10 to 15 stools a day. These are the kind, it's not just, I had like diarrhea for a day or two. That's not going to cut it. And then the same thing with the urinary loss. Everybody has protein in the urine, as you get along during the rest of the day. But these are folks who have flat out nephrotic syndrome. So they're usually swollen, and you can tell those folks. And then really worldwide outside the US, we have to worry about things like malnutrition and HIV. And so really, for our purposes, there's two types of mechanisms going on here. There's deficiency in antibody production. So your body is not producing enough antibodies as a portion of secondary immune deficiency, and there's antibody loss. We're not going to focus too much on antibody loss. That's not as common as the deficiency in antibody production. So where do you go from here? There are many, many drugs that induce secondary immune deficiency disease. So on the left-hand side of the screen, mark what the different mechanisms of these drugs are. And then on the right-hand side are examples of those drugs. So, probably most of us have heard or are familiar with anti-B and anti-T cell monoclonal antibodies. I think probably the most common that you may have heard is rituximab, but there's also other biologics, and now it's becoming more popular is CAR T therapy. There's tyrosine kinase inhibitors, tumor necrosis factor inhibitors, and immunosuppressants. So, these are steroids we use a lot. Methotrexate, anti-epileptics. Anti-epileptics, you have to be careful because they can cause hypogammaglobulinemia. So if we just took from this category, just the anti-B cells, that's what we really want to focus on, or that's what I'm going to focus on. It doesn't really matter what you all want to focus on. It's all me. And so what I thought would be actually more practical is B cell inhibitors, right? So these are a list of the B cell inhibitors, and you'll notice that there's a bunch of CD markers on the left-hand side. So things like rituximab, ocrelizumab, like this patient had, or Ocrevus. There's anti-CD22, anti-CD19. The point is not to memorize this list. The point is to know that these are out there and to get that clinical history from either the patient, or if the patient doesn't know, then you need to go seeking the subspecialist, either the hematologist, the rheumatologist, the neurologist. And most of these disorders in the SID space are used to treat autoimmune conditions or malignant conditions. Those are the two most common. The issue that we don't really know a lot about the long-lasting effects of these drugs. When rituximab first came out in the early 1990s, I was just a young whippersnapper, and the New England Journal articles said that people don't really get hypogam. That's not really a thing with rituximab. And what we're understanding a little bit more is patients who are on continuous rituximab, not just certain sequence of doses, or a certain population of those folks will actually go on to develop long-term hypogam and immune deficiency, even years after the rituximab has actually been stopped. So this is not just that, Niraj, you're still giving the rituximab. No, so we have to be cognizant in our history about what type of drugs these patients, report. And some studies showed increased rate of hypogammaglobulinemia following rituximab, and again, some which persist indefinitely, long after. So this is the only confusogram that you're going to see in this slide presentation. And it's not to say, oh my gosh, there's all these things going on here. But if you'll notice right there in the center is something called the naive mature B cell. And there's all these little receptors that are on the mature naive B cell. So the point of this slide is different biologics can attack the B cell in different ways. There's CD19 receptor antibodies, there's CD20 receptor antibodies, and usually the end result is the same. It's to blow away B cells and to get rid of, you might say, well, why in the world would you want to blow away B cells? If your B cells are producing autoantibodies, right, that attack yourself, well, if you blow away B cells, there's a good chance you're going to knock out that particular issue. Or if you have, let's say, EBV-driven lymphoma, and your EBV is inside B cells, and the lymphoma is a result of the B cells, well, then you might think, oh, I'll destroy the B cells, well, then I should produce a good result with the lymphoma. The one thing that I'll just point out is that the reason why in most cases of a short courses of rituximab usually doesn't make patients hypogammaglobulinemic. And the reason is because the rituximab works as an anti-CD20 monoclonal antibody. And you notice that that cell right in the middle, the blue cell, has an anti-CD20 receptor. But that's actually not the differentiated cell that produces antibodies. Differentiated cell that produces antibodies is located in the lower part of this lower part of this figure, kind of purple, magenta, is called a plasma cell. Plasma cell is the differentiated CD20 B cell that produces the antibodies. And what you'll notice is that the plasma cell is CD20 negative. CD20 negative. So rituximab does not affect plasma cells. And what is thought is that the short-acting, mostly, effects of rituximab blows away the B cells, and the plasma cells sort of take over, and they take over for the duration until the CD20 B cells can regenerate. But again, rituximab can have long-term issues where ultimately the B cells and the plasma cells can't do their job, or the CD20 B cells never recuperate. All right, is that all we have to worry about? Sadly, no. I wish it was, right? So there are some therapies, some are on the horizon, some that are being used with more frequency. And these are the agents that work in different pathways. But there's already FDA-approved drugs for something called the recycling antibody. This is this anti-FcRn antibody. It's a neonatal receptor antibody. And basically, it works by eliminating or blocking the receptor that autoantibodies block to. But it can end up, and the IG gets recycled. So you can theoretically get hypogammaglobulinemia. I think CAR T, most of us hopefully are familiar with CAR T therapy, and I'm going to show you, some evidence. But these therapies, make rituximab look like, a kindergartner, right? These are like the big folks. These are like the cannons, right? You have the cannons, and then you have sort of the mosquitoes, and these are the big cannons, and they're so profoundly immunosuppressive. Like, let's say for CAR T, is that there are some recommendations in certain countries that B cell depletion is known to be expected, right? Not even possible, but expected result. And some institutions go ahead and start their patients on immunoglobulin replacement at the onset of CAR T therapy, not waiting for repeat measurements to show hypogam. So these are pretty significant. So what is an allergist to do, right? What is an allergist to do? I know most of you know this, but most of what we do with these patients is still driven by the clinical history. So it doesn't matter, for primary immune deficiency disease, right? You have to have recurrent infections. SID is actually no different. So the primary thing is to get a history and a physical examination. And really, when I talk about history, I'm talking about an infectious history. And then you do what we consider is a lot of done in sort of an immune evaluation, CBC with diff, immunoglobulins, and you do IG responses to specific vaccines, diphtheria, tetanus, streptococcus pneumoniae, lymphocyte enumeration. And I think, the lymphocyte enumeration looking at TB and NK cells is a slightly different purpose here, right? In primary immune deficiency disease, you're really looking to see the abnormalities of things that might be evident in skin or Westcott-Aldrich, or if they have no B cells, you're looking at a Bruton's X-linked, a gamma-globulinemia. But really, the majority of what we're looking for in SID is actually B cells, right? You can bet your bottom dollar that you're going to have hypogam if you have 0 B cells, right? It's not always the case, but in most of the cases, yes. And then you can have low T cells with some of these disorders, so you have to be careful about increased susceptibility to infection. And then, generally some folks end up getting a urinalysis just to make sure you're not dumping loads and loads of urine. But, you can have some proteinuria, and that's fine. Again, most of these folks are really kind of edematous and things like that show loss of antibodies. What about other things, right? This is not necessarily things that we do in a primary immune deficiency evaluation, but what you're really looking for is you're looking for things, clues that might give you an idea whether somebody might have SID. So you can do a quick calculation. You can look at your serum protein albumin, and you can get sort of a globulin fractionation. That might give you a 4-person screening tool for hypogam. If they're having fluoride diarrhea or you're worried about stool loss, look for stool alpha-1 antitrypsin in the stool. And then, make sure that if folks are having increased infections, we always worry about, bug, drug, whether you have the appropriate bug and if it's, resistant. So, appropriate cultures may be indicated. And if somebody's had recurrent pneumonias or sinusitis or things like that, you might be inclined to get certain imaging because that can be really helpful. We had a case last night where somebody had recurrent pneumonias, was kind of recalcitrant to immunoglobulin treatment. Lo and behold, she had bronchiectasis. Okay, real important to keep in mind is that there are cutoff values, and not all cutoff values for immunoglobulin levels are the same. So it's important to understand the lab you're sending it to, the cutoff values, age specific, right? So hypogam in the SID population, why is that a problem? Because it can lead to recurrent infections. I don't think it takes up rocket science to figure out that if you don't have much of an immune system, well, then you might have sinusitis, otitis, pneumonia. Hypogam is defined as reduced serum levels. And quantitatively, it's really two standard deviations below the lower limit. The two standard deviations are really the 95% confidence interval obtained from healthy volunteers. And then what you can see on the right-hand side is as you go from term baby, 6 month, 1 year, 4 to 5 to an adult, you can see that the immunoglobulin levels change. So it's really important that you're not matching, infant or pediatric child, values of immunoglobulin to an adult and vice versa, because that does make a difference. Okay, back to this diagram, and now we're going to focus on probably one of the most common anti-CD20 antibodies, and actually, frankly, one that we have the most data on, which is rituximab. So the reason why I chose this one is because I think there's a lot of use of rituximab. Often we don't get consults on patients who are about to get rituximab. We get consults after they've already had rituximab and then they have problems, right? And so that's a big problem. I think that not enough of institutions actually do a kind of immune workup. So again, as I mentioned before, rituximab affects CD20, but doesn't really reduce significantly the plasma cells, which is why for short courses of Ritux, sometimes your immunoglobulin levels can be sustained or normal. And this is just a subset, right? Well, I don't want you going around saying, oh, Dr. Patel told us that every course of rituximab causes hypogam, and that's just not true, right? But clearly, some of these patients are affected. We don't know who it is. We actually don't know. We don't know if this is a genetic predisposition, if this is a primary immunodeficiency disease that they had all along that's being unmasked by something else. It's really unclear. And the incidence of this particular agent and hypogam also is very unclear. Management of serum immunoglobulins, again, prior to Ritux is not the standard of care. So when somebody gives rituximab, generally it's not pertinent in that, in terms of guidelines to get immunoglobulins, but I think it ought to be. So in one study looking at 179 patients with B-cell lymphoma, the use of rituximab caused hypogam in almost 40% of patients. And a smaller percentage, 7%, develop severe infections. When you talk about severe infections, you're really talking about acute serious bacterial infections. You're talking about pneumonia, meningitis, sepsis, bacteremia. You're not talking about, bronchitis or a cold. And in another study, 114 patients with any condition, so not B-cell lymphoma, but with any condition, lupus, rheumatoid arthritis, anything that they got rituximab for, about almost a quarter developed hypogam. That's significant.
Do you have a question? I know everyone's different, but a time frame for when this happens, is this like months after treatment or is this years?
Yeah, so let me repeat the question for the people who are attending on Zoom. So the question is do I have a time frame for after rituximab is given, when should we be looking for, when do patients develop symptoms of hypogam or recurrent infections? So historically, rituximab, usually within 3 to 6 months, if a patient is giving an average dose of rituximab, let's say 1 to 4 doses, 350 milligrams per meter squared, that's considered average. Then usually it takes about 3 to 6 months for the B cells to replenish. And maybe a little bit more time for B cells to start producing antibody, but generally about 6 months. Sometimes it can take a little bit longer, up to 12 months. I would say in general, usually it's after that, right? So sustained hypogam, typically beyond 12 months is usually when you start to see the development of infections. Now, it may be sooner than that, or it may be after that, particularly in patients who are on sustained every 6 months of rituximab, those are the folks who probably have more risk. Also, I'm going to show you some data to suggest that people who are hypogam to begin with, that is also a risk factor for future development of sustained hypogam as well as recurrent infection. So while there's not kind of an exact answer, there's typically, I would say 6 to 12 months and then beyond.
In the review with the core AI state of management of secondary immunodeficiencies, there was a bit of data showing in different conditions where rituximab is used, kind of different lengths of time that the hypogammaglobulinemia can persist. If I recall, like maybe the vasculitis, like the autoimmune vasculitis tends to be longer.
Yeah. So the question is that or the comment is that in certain conditions rituximab use can cause more profound hypogam or sustained hypogam, particularly in conditions that are rheumatologic or autoimmune, and then that's exactly true. One of the things that can predispose you to getting prolonged hypogam, recurrent infections, is not only the underlying condition, but the duration and frequency of rituximab. Typically, after 3 to 4 doses of rituximab, that's when the sustained hypogammaglobulinemia you start to worry about. And somebody brought up, a really smart person, Dr. Lang, brought up about the 2022 Quad AI guidelines for secondary immunodeficiency disease, and I'm going to bring that up in our workup for that patient who had hypogam. So thank you for mentioning that. Okay, and just a little comment about use of rituximab. Here's where we get into a little bit of some head scratching: is how do we interpret vaccine response in somebody who either has gotten Ritux hypogam or who's continuous on Ritux? But these folks develop cytopenic infections, and I think the question that remains to be answered is, okay, well, do they need immunoglobulin replacement? All right, as I was alluding to, right? Can we piece out, or can we take a subset of those patients who are either about to start Ritux or who've got Ritux, and can we figure out who's more likely to develop disease versus who is not? Doesn't happen very often, but if you're fortunate to get a patient referred to you who got Ritux, who had pre-Ritux gamma globulin levels, then a low level to begin with increases your risk. And I think this kind of makes sense, right? If you're low to begin with, well then, you're not going to increase all of a sudden. But I think what it raises the issue is that why were you low to begin with? And is there another underlying issue besides the autoimmunity or malignancy, like a primary immunodeficiency disease? Repeated courses of Ritux. So, actually, I guess 1 is not really a repeated course of Ritux, but just ignore the 1, 2 through 5. 2 through 5 is repeated course of Ritux. But usually, we've seen patients get 6 and beyond, and I think particularly the every 6 months or every 4 months of Ritux is a problem. Concomitant steroid therapy, and then certain chemos for malignancies combined with Ritux. The two together seem to be, it's like 1 + 1 = 3, seem to be more synergistic than either one alone. And, some experts recommend that a pre-Ritux should be done. Pre-Ritux evaluation should include serum immunoglobulins, B cells, which makes sense, right? And then plus or minus vaccine responses and pre-existing hypogam. So let's say you do this and pre-existing hypogam is evident, they should be examined for primary immunodeficiency disease. And there's no consensus even yet, about management of hypogam prior to Ritux. So if you do this exercise and you say, hey, I got this patient who's got hypogam and we're about to give Ritux. Now what do I do? You're not going to find a lot. And how about the diagnosis? So multiple factors or criteria can lead to the confirmation of SID. So I think this is another area where, well, what constitutes somebody with SID? So usually it's a person with an underlying diagnosis, like an autoimmune disease or cancer. Usually they've had some presence of immunosuppressive drugs. Again, this is something that you would get as in the history. And then typically you've done that evaluation that I showed previously, shown some functional antibody deficiency or very low immunoglobulin. We're going to talk about what very low immunoglobulin means, or at least in terms of clinical guidelines that we have. And so hypogam can really be associated with increased morbidity and mortality due to higher infection rates. So it's really important, again, for any disease, to diagnose these folks early. You want to diagnose these folks early so that you can intervene early. The longer these folks percolate, the longer they go on, the longer they have frequent illnesses, the more chance there is for them to do poorly. And one example would be end organ damage that's irreversible due to an infection. Why do we worry? What's the, say, yeah, big deal, Patel, so they have insulin, right? So insulin affects the immune function. And again, it varies in presentation and severity, but infections are common. That's what you really want to look at. And so it can predispose them to infections. And recurrent infection can lead to end organ damage and mortality, which is never good. And it's crucial to properly diagnose again and treat to minimize disease progression and life-threatening infections. And this is a little bit different, right, for how we manage primary immunodeficiency disease, right? Primary immunodeficiency disease, the image is that this is a genetic disorder on the one hand. So most of these folks who are on treatment, generally, unless they've had a radical bone marrow transplant or gene therapy, most of them are on treatment for that. Right? But what about SID, right? Somebody intervened, they were presumably healthy before, somebody gave them some biologic, and let's say they stop, or let's say they're going to stop, or let's say, could they reconstitute their immune system? And how does that look like? And what would you do? And how do you know when maybe to call off the dogs and maybe stop or wean the immunoglobulin? Those are questions that are confusing, and there's not a lot of great answers. This was one of the first, and I actually like this one. This was one of the first algorithms to kind of come out saying, hey, we have these patients with SID showing up in the allergy immunology clinic or showing up in the hospital where allergy immunology is consulted. What do we do with these people, right? And so I think my personal feeling is that it's important for allergists to kind of stick themselves into this algorithm. And I've got a little place on where to stick yourself into somebody else's business, which which I commonly do. But first of all, you have to have the hypogam, right? The hypogam, and then recurrent infections, right? So that's really kind of where you're doing. And I think that's really all you have to have. And then I think the evaluation, the management, I think this is where we can really shine as allergists. So we talked about testing immunoglobulin for specific antibody levels and levels of subsets. And then there's some other things if you're worried about protein loss. But the key clinical driver, just as I mentioned before, you're not going to do really much of anything, with rare exceptions, unless that patient is clinically not doing well. And in our arena, it would be frequent illnesses. So that's going to be the thing that's going to drive what exactly you're going to do with that patient. So in this algorithm, do they have infections? Yes or no? I like it. It's pretty easy, right? Yes, no. Like, when my wife asked me to mow the grass, like yes, no. Usually it's yes, right? Unless I, really want to spend some time in the doghouse. But just same thing. So yes, if they have frequent infections, then you would consider immunoglobulin replacement therapy. If they don't have frequent infections, well then you may use some of those clinical parameters to kind of decide, hey, do I need to do something? Because if your IgG level is less than 400, right? Even if you don't have infections, you are likely at increased risk for getting infections. So you got to think fast forward that, hey, what is the risk of something going wrong? And then you can see here that part of this is also the core specific response to antibodies. So in 2022, the American Academy of Asthma, Allergy, and Immunology working group put out guidelines for secondary immunodeficiency and how to manage. The idea is not to memorize this slide, but you can go, you can Google, like how I get all my medical information, and you can just Google the SID working group, and this is available on this. So this is, I think it's figure 2, but this shows you an algorithm on how to deal with somebody who has secondary immunodeficiency disease. And it's actually not much different than the slide that I just showed you, right? So the key clinical drivers, do they have infections? Yes or no? Do they have hypogam? Now there is a caveat here. If they don't have frequent infections, but they have an IgG level less than 150, you're going to start them on immunoglobulin, for sure. But if they have frequent infections and their IgG level is less than 400, you're going to start on immunoglobulin, or at least talk about immunoglobulin. If they have frequent infections, and their IgG level is less than 700, and they have a low IgA and or low IgM, you're going to talk about immunoglobulin. On the other hand, on the other side of the coin, and there is some room for antibiotic prophylaxis, and on the other side of the coin, it gets a little bit more complicated, right? If they're feeling well, then most of it is monitoring, unless their IgG level is less than 400. Then you have something called the shared decision making, right? Shared decision making is where you and the patient or the parent talk about, whether immunoglobulin replacement is right, and you come across all the risks and benefits and the pros and cons and lifestyle and things like that. All right, so I just want to share with you that we don't talk about how to prevent illnesses. Like once the patient got an illness, we talk about that, but we don't really talk about how to prevent illnesses. So this is just to kind of talk to you about some cold and flu and prevention tips, and I got this from The Onion, which is a really beautiful website about allergy issues. So to prevent infections, have sick people off into your food. You can actually do this, and a slight inoculative dose of germs will boost your body's defense against a full-blown infection later. Pack your sinus cavity with Vicks Vapor Rub to fully ventilate your respiratory system. Sometimes a severe respiratory infection will just cause the lungs to fill with fluid, right? Why would you want that? So if that occurs, make sure you flush your lungs repeatedly with boiling hot water to clear them, and getting a hose down your windpipe will help get around that gag reflex. But I think this is the most important. Sneezing into a handkerchief just redirects the germs that catch you. Why would you do that? So always sneeze outwards so as to shoot the germs as far across the room as possible. So let's get back to our case, right? So this is a 62-year-old female, just to recap, multiple sclerosis, started ocrelizumab, which is an anti-CD20 antibody, but she's on it every 6 months. She's had 2 pneumonias in the last 12 months, 3 to 4 sinus infections, 2 ear infections as an adult. Her immune evaluation showed an IgG level of less than 400, 383, normal IgA and normal IgM with poor response to vaccines, and her CD19 B cells that produce antibodies is completely absent. So, what would you do with this patient? Do you monitor only? Maybe? Start antibiotic prophylaxis? Do you start immunoglobulin treatment? Do you run back to your room, look up the QuadAI 2022 guidelines, and go through the algorithm? Totally good, right? So, what do we do in this case? Do you monitor only? I don't think so. I don't think, several guidelines would say no. You don't just monitor only. Why? This person is symptomatic. 2 pneumonias, one which is radiographic improvement in the last 1 year, 2 ear infections, recurrent sinusitis. That's a symptomatic patient. So you wouldn't just monitor only, and you wouldn't monitor only because the IgG level is less than 400. So in both of those algorithms I showed you, less than 400 is to get your attention. And this 400 people have, but when do they get the 400 from? I think this comes out of some data, both in the SID, CLL, and multiple myeloma. 400 seem to have worked previous to the 2022 guidelines, and so it just stuck. Do you start antibiotic prophylaxis in this patient? Now that is a potential possibility. I would say if you look at those guidelines and you look at the patient, I would say again, no. Our antibiotic prophylaxis only is just to give that person, low dose, typically half the dose, biotic to try and prevent infections. And you would do that, if the patient was maybe IgG level was greater than 400. But in this case, the algorithm would kind of tell you, hey, unless she's asymptomatic and she has an IgG level of 400, you're not really going to do antibiotic prophylaxis. Do you start IgG? You start immunoglobulin replacement therapy, and in this case, I would, because she has future recurrent infections. Her IgG is less than 400, and let's say you've just excluded other causes of SID. She doesn't have, chronic diarrhea. She's not on any anti-epileptics. This is pretty clear cut. So that's what we did in this case. The IgG, just to let you know, there's nothing magical about the dosing. It is actually the replacement dosing that many of you are familiar with, 400 to 600 milligrams per kilogram every 4 weeks if you're doing IV Ig, and then 100 to 150 milligrams per kilogram per week if you're doing a conventional scheme. And I don't think you would really do something else, right? I mean, nobody would just say, yeah, okay, I think this is, fine. I mean, if you felt nervous, you might refer, but I would encourage you to kind of, as an allergist in your practice, to really become at least the go-to person for the evaluation, at least try and thinking about this, because I think this is going to kind of show up, if it hasn't already, increasing frequency in your practice. So IgG replacement, again, this is the routine replacement 400 to 600 milligrams per kilogram. And then, of course, as we put patients on immunoglobulin, we talk about patient considerations. This is a shared decision making, pros, cons, side effects, place of administration. And then the big question that we have no idea is duration, if and when to stop. And when I say no idea, there are some general guidelines in the 2022 working group, but I'll be honest with you, they're very general, and everybody is going to have to be individualized. And so you can use that as a kind of sidebar. And what these folks ought to get, just like anybody else on immunoglobulin, is serum immunoglobulin levels periodically, blood counts, chemistries, liver function. So what's going on in the world, right? That's what I keep asking about, not necessarily about immunology, but guidelines that recommend immunoglobulin for SID treatment. It's all over the place, right? There's actually no really universally accepted guidelines. What we do in the US is different than what they do in the UK, which is different than Australia, which is different than this probably European group called ESCMID. Basically, in the US, if there's absent or deficient antibody production and recurrent or severe infections, this comes out from data and guidelines. We actually have guidelines for CLL and multiple myeloma. UK is slightly different. I'm not going to go over what people are doing halfway across the globe. I just want to let you know that this is an evolving area. We don't have a consensus, and the good news is that people are studying this, and we're having longer term data. Just understand that most treatment guidelines, right, including these on the use of immunoglobulin on SID, do not provide guidance on specific etiologies of SID. So is multiple sclerosis different than multiple myeloma? We both have multiple in there, right? So maybe it's the same, I don't know. But there's no disease-specific guidelines, and that's a problem, right? We don't have that granularity. There's really not very good guidelines on monitoring. Like, what are we supposed to do? How do we know that it's time for them that their immune system is reconstituted? Maybe it's time for them to get off of immunoglobulin. There's a couple of tips and tricks, but there's really no consensus that can be applied to people broadly. Guidelines for effective use. Again, there's no guidelines for monitoring. Guidelines for management of hematologic malignancies. Say that prophylactic IgG may be useful, right? And you can kind of see, and now you know kind of the structure where somebody presented with recurrent infections, how immunoglobulin might be helpful, right? But again, most guidelines don't give guidance on specific etiologies. And again, we're still stuck with this thing where, when did the hypogam occur? Did it occur after retux? Did it occur before the retux? And what do we do with patients who are continuously on retux and have no hope of getting off of that anytime soon, right? As I mentioned before, the other thing that we have to understand as allergists is vaccines, right? Not only kind of timing of vaccines, but also, what to do when somebody's gotten rituximab, so therapeutic vaccines, but also kind of diagnostic vaccines when we use vaccines to see whether somebody has a specific antibody response. There are multiple studies looking at different drugs and looking at, in particular, pneumococcal polysaccharide response. And I'm not going to go over all of those. And again, I think just for this purpose, because rituximab is popular, we're going to just focus on the data for retux. But anti-CD20 antibodies, you can see here for the pneumococcal vaccine, it can have a profound response on your ability to produce a response to the pneumococcal polysaccharide. So now you might be shaking your head. Well, you just said, Dr. Patel, that I'm supposed to be assessing that during my initial evaluation, but how do I interpret that if the patient's on retux? And I'm here to say the answer is, I don't know. Nobody knows, really. And that's something that is not very well specified. Now, there is an updated guidelines coming out, hopefully either the end of this year or likely 2025. It's going to be updated to the 2012 diagnostic guidelines on vaccination that will hopefully have updated information. But that is a big question mark. And so I get it. There's some stuff that we don't have. Seasonal influenza vaccine causes a substantial decrease if you give rituximab. Hepatitis B vaccine unknown. So it's important to measure vaccines before, during, and after retux, or at least understand where the patient's journey is. Are they before the retux? Are they during the retux? Are they after the retux, right? In one study, 75 adults with diabetes, not the same thing, but with diabetes were treated with 4 doses of Ritux. Okay, that's kind of the average in the pediatric world. They were looked at tetanus, diphtheria, MMR, bacteriophage by 174, which got its claim to fame at Seattle Children's, Dr. Hans Ock. So pre-existing immunity was not impacted. Okay, pre-existing immunity was not impacted 12 months after Ritux. So the studies are good that if you give vaccines or patient has immunity prior to Ritux, you're in good shape. Now, MMR was not given typically because of the concern for immunosuppression, vaccine-associated disease. But the problem is if you give vaccinations during Ritux, well, the response is severely depressed. So not as great. Vaccination given 12 months post-Ritux. So, this is when patients were actually stopped on Ritux, given vaccination. Most patients actually responded, right? So, but the titers are slightly lower. So it does matter if they stop the Ritux, when in that journey, might you consider a good response to vaccines? And the recommendation really is primary non-live viral and polysaccharide vaccines should be given at least 2 to 4 weeks prior to Ritux. The issue is that we don't see those patients then. We see them afterwards. So I get it. If you're associated with a hospital institution or a group, or you have colleagues in the hem-onc space or whatever, you might consider some kind of conversations to try and figure this part out. Either measurement of immunoglobulins prior to Ritux, vaccinations. I think it's important for us as allergists. Revaccination after B-cell depleting therapies. Rituximab can impair vaccine responses, which makes it very difficult for us to interpret when we're doing an immune evaluation. Influenza vaccine given 4 to 8 weeks after Ritux were associated with markedly reduced antibody response. But if you gave it 6 to 10 months, was just associated with a partially reduced response. Again, the timing to let the rituximab out of the system, let the reconstitution of B cells. Now, it even says in the absence of B cells, these were probably plasma cells and other cells that were CD20 negative that were doing the work. Factors consider whenever you're doing or considering vaccines are concurrent immunosuppression. So some patients can't get off of immunosuppressive medication. So, you have to take that with a grain of salt. Autoimmunity and cancer can both be immunocompromising conditions, particularly if they've had treatment for that. Did they have chemotherapy? Did they have, transplant? And then, of course, consider an underlying primary immunodeficiency disease in particular appropriate cases. Revaccination after they've had B-cell depleting therapies, again, administered 6 to 12 months after the last dose of rituximab. Live vaccines should be withheld until B-cell counts return and are in the normal levels. And usually, if you can demonstrate B-cell function, right? So B cells, let's say B cells are reconstituted. The reason why you don't want to give varicella and MMR and let's say the live, oral typhoid vaccine or BCG or whatever live vaccines is because you don't want the problem of vaccine-associated disease. You don't want to give chickenpox to somebody if you can help it. But we do know that if they can produce response to other vaccines, that's a usually pretty surrogate marker for tolerance to live viral vaccines. And so waiting at least 12 to 6 months is generally advisable, or if you can give it 4 weeks prior to the next dose, if they're on continuous Ritux. All right, so just wrap up. What are the take-home points here? SID is most commonly caused by drugs and lymphoproliferative disorders in the US. That's it. Patients with SID have an increased risk for infection, as I showed you, which may be life-threatening because of quantitative, so can't produce enough immunoglobulin, qualitative, the antibodies don't work as poor response to vaccines, and infections can vary widely. So you can have somebody that has mild infections, somebody has severe infections, or somebody that has mild that develops severe infections. You have to be careful. You can't just, ignore those that are having sort of frequent illnesses, but are a little bit on the mild side. And then recurrent infections in patients with SID can lead to end organ damage. I think that's the big issue and why we worry about these folks, and it can lead to mortality. So for patients with SID, it's crucial to promptly diagnose and treat. Why? To minimize disease progression and life-threatening infections. I think this is true for any chronic disorder. And a full immune workup includes measurement of specific antibody responses, getting a clinical history about the frequency and the type of infections, and it's really required, to assess the potential susceptibility to infections in patients who are hypogammaglobulinemic, and you then use that information to go down that algorithm and say, hey, where does my patient fall? And then use some of your clinical judgment to see what is their future risk for infection and morbidity. And then again, there's guidelines for immunoglobulin replacement therapy, but they vary in SID, right? I think I showed you that there's a guidelines in the 2022 working group, and there's little to no guidance for duration of treatment. We use some markers like the production of IgA and IgM while somebody's on immunoglobulin, right? Or the following of reconstitution of B cells. You can do neoantigen in terms of trying to figure out antibody responses while somebody's on vaccine. So with that, I will close. I thank you everybody for your attention. Happy to take any questions you might have.
Question in the chat.
Okay. Okay, there's a question in the chat from Vinod, a patient who I was working up before rituximab. I had known her for a while. Her brain suggested rituximab, not that they recommended workup higher. Got it. Okay, very important. Thank you for that clarification. Showed a hepatitis B antigen positive. Okay, that's not good. Turned out later that she got Hep B vaccine 1 to 2 days prior. Found out later. Did not know that vaccine caused this positive test. Just an observation. Wondering if you had any comments. Thank you. Okay, so this goes along with hepatitis B vaccine, right? And hepatitis B antigen. So there's a couple of surface antigens that are present in hepatitis B. There's a hepatitis B surface antigen, there's a hepatitis E surface antigen, and then there's a couple of antibodies, hepatitis B surface antibody, hepatitis C, which is the core antibody. And the reason I'm pointing that out is because when somebody gets vaccinated versus disease, versus whether you get exposed to the hepatitis B virus, things happen with the hepatitis B antigen as well as your immune response. And you have to measure all of that. So first of all, I'll get to your point in just a second, but the marker of hepatitis B immunity is hepatitis B surface antibody. You want a hepatitis B surface antibody to be positive. That is an indication of immunity to hepatitis B. What you do not want is hepatitis C or core, hepatitis B core antibody to be positive. That indicates that the person's had past infection. So hepatitis B surface antibody can be present either with past infection or with vaccine. If it's just present without the core, it's vaccine only. So let's take the timeline. So hepatitis B surface antigen, that is a marker of being exposed to hepatitis B. So when you are exposed to hepatitis B, whether it's the vaccine or whether it's a hepatitis B virus, the first thing that your immune system is exposed to is the hepatitis B surface antigen. Hepatitis B surface antigen is a marker of the initial phase of hepatitis B. Then your hepatitis B IgM antibody goes up, and then the hepatitis B IgG goes up. But the hepatitis surface antigen is typically, see, if you have a hepatitis B surface antigen, it generally is indicative of ongoing active infection, and that's bad. You do not want that. However, you can get hepatitis B surface antigen transiently, just like in this particular case. So you're injecting hepatitis B surface antigen in the hepatitis B vaccine. And that is present in your body, detectable for the first couple of days. And then after that, you get development of hepatitis B surface antibody, both an IgM that comes first and an IgG that comes later. And so the best that I can comment on this is it likely was that you measured hepatitis B surface antigen very close to the administration of hepatitis B vaccine, which that's not usually done. It just happened to be in this case. So great question. That's sort of the pharmacokinetics of hepatitis B infection and the development of antibodies.
Good question. I come across a few situations where patients are referred from rheumatology or neurology being treated with B-cell depleting therapies. had hypogammaglobulinemia, and the providers were really worried about continuing those treatments because of worry and second. And my take was probably we can manage that, but I was wondering what's your take on it?
So there's this really smart lady in the room. For those of you who are on the Zoom, Dr. Lang asked a question about what do you do in a patient who is on, let's say, an anti-CD20 B cell depleting agent? They have some underlying autoimmune condition. Let's just say in this case MS, because I've actually had this point come up. What do you do in terms of the, on the one hand, you have SID, hypogam, frequent infections, but then on the other hand, patients who are continuously on, let's say every 6 months, of an anti-CD20 antibody, do you, at what point would you say, I think you need to stop the anti-CD20 antibody, let the immune system recover, and your infections hopefully will resolve? And I think this is a very delicate issue. There's not a one-size-fits-all. I think for certain conditions, and in particular, MS seems to be a big player here, is that in some patients with MS, if you stop the anti-CD20 B cell depleting agent, their MS will come back. And that's a huge problem, right? It's much better to have their MS under control or to have certain conditions under control than to stop the anti-CD20 B cell depleting agent. So I think I think it's always a risk-benefit ratio. Anytime you're introducing a medication or taking away medication, you have to understand risks and benefits. I've had actually several patients who are on B cell depleting agents, and we had discussions with the neurologist or the rheumatologist, and it's far much better for their quality of life, for their clinical condition, for the stop of spread of their underlying disease, for them to continue the anti-B cell depleting agent. And what we did in those cases, we did the immune evaluation, they were sick, they had hypogam, we put them on immunoglobulin replacement therapy, and we just said, hey, this B cell, this immunoglobulin replacement is likely going to be lifelong, or at least as long as you're going to continue on B cell depleting agent. That's a great question, but I don't think we have really enough, enough data to really figure that one out. But I think it definitely first started with the conversation with this discussion. It's a great question. There's another question in the chat. With the widespread use, I knew this was coming. With the widespread use of Prevnar 20, you can't make this up, by the way. I am struggling to measure response to polysaccharide antigens. How are you handling this? Funny you should ask. I just happen to have, I did happen to have, I guess maybe it got removed. I had some backup slides talking about the move to the conjugated vaccine. And the reason is because, here we go. Thank you so much. Why? Why do we worry about Prevnar 20 as an allergist, right? This is a big, huge problem. So Prevnar 20 is a conjugated vaccine, right? And so conjugated vaccines are test T cell dependent pathogens. I'll explain that in just a second. The problem is that in April 2023, Prevnar 20 is now the recommended vaccine for children, so part of the child immunization series, for adults, for people with chronic diseases, and Pneumovax PPSV 23 is slowly being taken out of circulation. Why is that a problem? The problem is that let's see. The problem is that when we look at the vaccines, we as allergists, right, are think about things in two ways when we're trying to diagnose somebody: T cell dependent, T cell independent. And what that means is that certain vaccines, like the Pneumovax, like the ones that are currently in stock that we use, that was in this patient, are T cell examples of a T cell independent polysaccharide response. That's one immune pathway. But then there's some more common T cell dependent, which Prevnar 20 now falls underneath here. So the Prevnar 13, Prevnar 15, Prevnar 20. Why do I make such a big stink about it? It's because you can actually have a normal response to conjugated dependent protein vaccines, but an abnormal response to the polysaccharide. So if Prevnar 20 is here and here to stay, and Pneumovax is going away, what is an allergist to do? And that's a big problem. And I don't have the answer for you. I just want to bring that up to say that now you have even more problems. But we are working on it. There are people who are writing guidelines. One of them may be actually talking right now, who are talking about updated guidelines for the use of pneumococcal vaccine. So what I would say is that there's a move to get rid of the pneumovax completely by the December 31st, 2024. So if that didn't produce enough anxiety for you, there is potentially that it might stay on a little bit longer if a drug manufacturer takes over. But by the end of December 31st, if nobody takes over, pneumococcal will be gone. And that's, so what do you do for polysaccharide response? I don't know. There is the polysaccharide salmonella vaccine, but realistically, it's not a commonly used vaccine. There's not a lot of commercial labs that actually measure the response. And so, there's more data to come. So, for now, I'd say if you can get Pneumovax, that's a great way to test the polysaccharide. But just be aware that it's not really Prevnar 20 is not really a substitute for Pneumovax. And once you give the Prevnar 20, it's going to be very difficult, right? If they have a good response to Prevnar 20, then how do you measure, polysaccharide? You give them the Pneumovax, but then do you need to have 2 or 3 titers that don't respond? And I don't know. Nobody really knows the answer. So great question. Very few answers. It's another question. I don't know if we have time for one more question.
More than we.
Okay, more than we cut it out. It's 8:06. Okay, I'll try and be quick. This is. Do you have any comment on IgG subclass? And more recently, I'm noticing IgG4 disease being diagnosed. So IgG4 is abnormal value in about 10 to 20% of the normal population. So, IgG subclass 4 is not a great way to test IgG subclass deficiency. I think you'll find that in the updated guidelines in 2025, there's going to be a comment on IgG subclass deficiency. So in 2015, the primary, the QuadI guidelines for primary immunodeficiency is being updated in 2015. There's a section on IgG subclass deficiency, but I think the current feeling is that IgG subclasses and subclass deficiency are going to kind of be reduced and maybe even possibly go away. The reason is because with IgG subclass deficiency, you have to have poor response to vaccines in addition to that. So, if you check poor response to vaccines, that's really sort of the meat of IgG subclass deficiency. And with that, again, thank you all so much. Really appreciate the attention. Thank you.